So I ask all the speakers of today to switch on their cameras, and I will start with the questions that were put in the chat. One is a question from Win Jensen. If Cochrane Rehabilitation would be capable of providing training in evidence and research, or is only focused on presenting the evidence. Stefano, do you want to reply, or I don't know if Julia is.
I don't know if Julia is there. We don't see the camera. Okay, Julia is there.
Yes, all right. So thank you for the question. So the question is Cochrane Rehab capable of providing training, evidence, and research? Or should we just focus on presenting the evidence? Well, it depends on the capacity that is required. We will be able to, I mean, because we have the education committee as well as the methodology committee, so it can be the combined effort of both working area. And if we have to ask one over the other, I suppose it's a very difficult question, because really we do need to focus on presenting the evidence as well, because otherwise it will be very difficult for, I mean, we have to show how to implement the evidence. So we do have to do both. And it depends, I mean, just to share with all of the of the participants, when we did the survey, it seems that quite a lot of participants or the respondents actually favored online courses. So that gives us the advantage to reach more and more, especially if we're able to do both synchronous and asynchronous online courses. So I suppose that the training and evidence research can be done via online, and we can also show them the other resources, but we should focus on presenting the evidence pertaining to rehabilitation. I hope that answers your question. Or maybe Stefano want to add on that?
Yeah, I can add that for the Cochrane knowledge translation strategy, that means the way to convey evidence. We don't have only the push, so sending out the information is always, we also have the pool, and the pool is based on the need of people of knowledge that comes from developing the need. That means the more you educate to evidence, the more you educate on how to gather information and relevant information from the literature, the more people will ask this kind of evidence. So it's really a combination of the two. You need the two things. And since the start, in fact, we had the education working area as one of the 5 areas of work of Cochrane Rehab.
Thank you. Then there is an interesting question from
Carlotte. Francesca, Carlotte wants to add something, I think. No problem.
Yeah, very briefly. Thanks, Wim, for the question. I think hearing what I heard this morning, I'm even more convinced that we also should work on training, because the aim of and the vision of Cochrane Rehab is to make sure that all the professionals practice evidence-based, do evidence-based practice and implement it in their practice. And from what I heard today, really, it seems that basic education, and I'm quite is still lacking in many countries, much more than I even thought. So that's also what Nikos brought up as working on with the board. So I think we really, if we don't do also the education and the training of the people on how to use it and how to bring it to their practice, it will never be implemented. So my answer would be clearly yes, we should do it. Thank you.
Thank you, Carlotta. I also agree with you. And then there was a comment from Symphorian Kambu from the Cameroon, and partly Farouk has replied, but the question was about the diffusion and translation of Cochrane Rehab rapid systematic review on COVID-19 and in general of Cochrane systematic rapid reviews on Cochrane-19. If we anyhow measure the impact of how this recommendation have been integrated in the clinical guidelines in COVID management in our countries or in any low and middle income countries. I wish for an example, and if we have any information of a successful experience of integration of this evidence on COVID-19 rehabilitation in the global COVID management policies in low middle income countries in particular. I don't know if Maria Gabriela wants to reply or someone else. Maria Gabriela, you're muted.
Thank you, Francesca. This is a very nice question. I do not have the answer. I don't know whether Stefano has the answer because it concerns the knowledge translation. And unfortunately, knowledge translation is a very, very slow process. I do not have experience about what happens now, what is happening now in low and middle income countries about the use of this evidence in order to change, update the rehabilitation care, rehabilitation provision or healthcare provision to people with COVID-19. In Western countries, in Italy, for instance, there is a growing, but not very rapidly growing, so very slowly growing interest into the long-term sequelae of COVID-19. I believe that most attention is still focusing on the acute phase, and irrespective of the fact that there is a very impressive evidence about the long-term consequences of COVID-19 that should deserve an increase of staff resources and resources allocation to rehabilitation for these people. So my personal feeling is just a feeling, no more, is that there is not very tight and rapid translation of the information we are gathering, the evidence we are gathering into actions on the part of the governments.
I can only add that one of the problems that we have with Cochrane is measuring the final outcome. We measure what we throw out. We are not able to measure what is kept in the different systems, and is an issue that Cochrane is trying to face. And then when we will have some kind of measurement, one of measurement is the introduction of the evidence into the guidelines. So we can say that for that we have a huge impact because we are helping WHO producing their guidelines based on our evidence. So that is already an impact, but is not the final outcome. The final outcome is how that will be used, and I don't know if at WHO level they have any experience on that. But the metrics there is still really missing.
I don't know if Farouk or Rabena wants to add something.
Thank you. I think that in terms of the evidence and then in the management of COVID in low to middle income countries, I think that, yes, there is the evidence, but organizing it, getting it into clinical guidelines, it takes a little bit more effort. So an example is when it started in Ghana and we were developing, the Ghana Health Service was developing a protocol, a package for managing COVID-19. Quickly, with the help of other people, we put together the evidence that was available for rehab for COVID-19, and we put it together and managed to get it as part of the package or the manual for managing COVID-19. It took a lot of lobbying and pushing it forward, and then trying to do some training as well in terms of providing rehab. And so I think that it would help probably if there's a standardized guideline, especially for low to middle income countries where rehab is not really known. But I think that it can be done, and we have an example of something like that.
Farouk, do you want to add something?
Yeah. So first of all, like talking from Pakistan, unfortunately, rehabilitation was never a part of COVID response, either in the acute phase and even after 1.5 years. I mean, officially. But what I am trying to do nowadays, I am actually proposing and I'm promoting this concept that long COVID is actually a window of opportunity for rehabilitation professionals. And why do I say that? Because I say this from my own experience of 16 years back when we had this October 2005 earthquake, the largest one in the history of the country, hundreds of people with spinal cord injuries. And that was a turning movement actually in history of Pakistan, where many people started realizing the value of a multidisciplinary integrated rehabilitation, because the spinal surgeon, the orthopedic surgeons, they did what they could do, but they could not manage spinal cord injuries. And if I see 15 years down the lane, things have improved a lot. So what I tell my colleagues, yes, translation is important, a very slow process, takes a lot of time for diffusion. But if we start today, if we put in the seed today, probably in a couple of years, we are going to reap the fruits. So I'm actually nowadays in my personal capacity and from my organizational point of view, I am promoting this concept of long COVID rehabilitation, because we are almost over with the acute phase, but there are people who are coming back, have their issues, and our people in pulmonology, acute care, they are not very well conversed what this chronic COVID, and long haulers are. So if you ask me from Pakistan point of view, yes, we missed the first strain of acute COVID, but we are working on this long COVID. And I'm telling my colleagues, and many of them are actually working both sides. Some of them are writing articles and reviews, and some of them are actively promoting and providing services. So I do hope that a good outcome will come out of this effort, if not in the short term, in the long term.
Thank you, Farouk. I give the word to Walter. Wants to add something, I guess.
Yes, thank you. And I guess even if it is from the Pakistan perspective, as in a professional as Farouk and as a researcher in a country, even for WHO, the situation is the same. Just to say that the COVID-19 pandemic has, although because of its huge impact and the suffering of people, has raised an awareness even within WHO about rehab. There's the clinical management handbook for the COVID-19. We have a huge chapter on rehabilitation that is included in this clinical management handbook. Previously, we would have clinical management teams within WHO with the medical specialties, but now there's somebody that is a rehab representative at the table, and that is even new for WHO. So the COVID-19 pandemic, with it lots of its misfortune, has some opportunities for rehab. We have been the third in our global series of webinars, and we have been organizing the rehabilitation for post-COVID-19 condition, which has been a global webinar. We are presenting in many conferences, and indeed, currently, we are synthesizing the evidence to produce our rapid advice guideline for the rehabilitation of post-COVID-19 condition. And I agree with Stefano in terms of the uptake. So Cochrane may compile evidence and then WHO developing guideline, and then we don't know yet still whether guidelines will be uptaken. And that is even something we cannot measure. I mean, and I agree with Stefano, we don't have that metrics in developing dissemination and the data chain that is involved in terms of country uptake, and even from WHO, we hope that the products that we develop are discovered and used. That's it for now.
Stefano?
Yeah, I want to go back to one of my last slides that was surfing the wave, and I think that we are really in incredible times for rehabilitation, since for many years we fought to make ourselves recognized, but if we miss in terms of unity, one of the big mistakes we could have done as Cochrane Rehabilitation would have been called ourselves Cochrane Physical and Rehabilitation Medicine, just because we started from our medical specialty. But Cochrane Rehabilitation means all together. And the WHO Rehabilitation Program means all together, moving as all the professions together to increase the world and the quality of the services provided for rehabilitation. And if we are able to do that, we will have a very good table to surf the wave of the people requiring rehabilitation that are increasing. If we just go everyone by ourselves, we will be like the, just decreasing the power of what we can do. And also the unity that we are creating through the rehabilitation program and Cochrane Rehabilitation and the institutes working globally to strengthen rehabilitation. I think this is unique and we must do it even more than before.
The last question is also from Symphorian. As you know, we recently had this event in Cameroon where Uter, as a representative of the WHO, participated, Carlotta participated, and he's trying to scaling up rehabilitation in his country, and is questioning if there are evidence on cost effectiveness of rehabilitation provided that can be provided by the WHO to advocate for an increase of financing rehabilitation in low and middle income countries. This is probably the key question for
yes, and beside all the work we are already doing, we still need to focus on that one. Completely agree, the need is huge, but we are embarking on, there have been webinars now on the financing for rehabilitation for universal health coverage. The return on investment case is currently in the pipeline. And the need is there. I completely agree. And probably, of course, there will be different channels in terms of advocacy and make sure that governments include rehabilitation into their strategic planning. The World Rehabilitation Alliance, which is a collaboration with WHO, will also work in terms of advocacy, availability of services, their impact in terms of reducing length of stay, prevention of secondary complications, improving health outcomes of other health interventions. So the advocacy part involves more than the return on investment case. When it comes to the return on investment case itself, it is currently in the pipeline and looking at the next biennium to produce.